Welcome to today's Ask the Experts virtual session on improving health disparities in rural communities. My name is Martha Yaide, and I'm the Senior Director of Social and Behavioral Health at ASTHO. The purpose of today's Ask the Experts virtual session is to highlight the intersection of research, policy, and practice of public health programs in rural communities. This platform is an opportunity to invite an engaging discussion among the panelists from different disciplines at the local, state, and national levels. We hope that you will benefit from the panelists' different areas of expertise and perspectives. I'm honored to welcome you to this virtual session on behalf of the CDC. This virtual event is the third of a three-part series highlighting research and tools developed by PRCs and the intersection of research and practice. The Prevention Research Centers program consists of 26 public health universities or schools of medicine that conduct community-engaged research. Each Prevention Research Center designs, evaluates, and implements health promotion and disease prevention programs that reduce health disparities. Today, we'll highlight rural health programs developed by the University of South Carolina Prevention Research Center and the University of New Mexico Prevention Research Center. Our four goals for this webinar are to facilitate discussion between public health experts, identify policy, systems, and environmental change strategies for promoting public health in rural settings, gain a better understanding of how public health can incorporate innovative practices like telemedicine to improve health disparities in rural communities. Learn how state health departments can partner with prevention research centers and non-traditional partners to implement and adapt public health programs for rural communities. Before we get started, I would like to provide an overview of the logistics for this afternoon's webinar. Please log in to both the Adobe platform using the link provided and call into the number. This webinar is currently being recorded, and a link to the recording and webinar slides will be sent to you via email approximately 2 weeks after the event. We invite you to participate by typing your questions into the on-screen chat box at any time during the virtual event. If you are having technical difficulties, please let us know through the chat box. We would like to take a few minutes for each presenter to briefly introduce themselves and describe their area of expertise and current work related to rural health. Diane Hall, will you please introduce yourself?
Hello, everyone. Good afternoon. My name is Diane Hall, and I'm a lead health scientist at CDC in the policy office in the Office of the Director. A lot of people don't realize CDC has always done work in rural health, but within the last year or so, our work has become much more visible. And beginning in 2017, we began speaking more about CDC as an agency's, our portfolio of work. I categorize our work into science, program, and policy, and throughout all of that, communication is really critical. One of my roles is to serve as a point of contact and coordinator for our rural work. So I want to start with our MMWR series, which really was the catalyst for a lot of our work. So in 2017, CDC published 13 reports as part of our MMWR series that specifically focused on rural health. So you may know that MMWR is CDC's primary vehicle for scientific publication of timely, reliable, objective public health data and recommendations. The topics for the reports are listed on the slide, and while we are not planning on doing another annual series, we do continue to focus on rural for some of the MMWRs. So for example, in February of this year, we released a report on rural COPD, and just this month, a couple weeks ago, we released a report on rural obesity. So the first report, which really kicked things off, demonstrated that Americans living in rural areas are more likely to die from 5 leading causes of death when compared to urban counterparts. And those are heart disease, cancer, unintentional injury, which includes motor vehicle crashes, prescription drug overdose, and falls. Chronic lower respiratory disease is the 4th, and then stroke is the 5th. part of what was different about the series was we also wanted to do more comprehensive communication efforts. And so 5 of those topics included editorials in leading journals, including the New England Journal of Medicine. And 5 of the topics also included webinars, which were done in partnership with HRSA's Federal Office of Rural Health Policy, and those are housed on their Rural Health Information Hub. But one of the things our office wanted to do was really find a way to extend the reach of the information in the MMWRs. MMWR is a great publication and has great reach, but it is primarily a data report, and often readers aren't sure what to do next. So our office worked with subject matter experts in science and policy across CDC, and we developed 6 policy briefs for 6 of the topics. CDC staff also did Hill outreach and did Hill briefings, particularly on the injury reports. So these reports actually, the MMWRs caused quite a splash. And all of these are available, the MMWRs are available either through CDC's Rural Health page or the MMWR page. And the policy briefs are also available on the Rural Health page, and I'll show those URLs in just a slide. But they're also available on a new policy website that our office just released. So that's science, then policy. And a quick example of program that focuses on rural is addressing social determinants of health, specifically looking at high obesity, the high obesity program, which was designed to focus on adults or counties that had 40% rates of adult obesity or higher. And the intention was to focus on increased access to physical activity and healthy foods. And these funds went out through the university, the cooperative extensions. And so one example is Auburn University in Alabama. The folks there were able to create walking trails and biking trails, safe routes to schools, and farmers market food pantries.
Thanks, Diane, for that introduction and introducing us to those valuable resources. So next we'll have Lynn Gallagher introduce herself. Lynn?
Great. Thank you so much for this opportunity. My name is Lynn Gallagher, and as mentioned, I'm the Cabinet Secretary for the Department of Health, and I have been with the department since 2013. I want to talk to you first about the general makeup of our state. So approximately 1/3 of our population lives in rural areas. Hispanics make up about 48% of the population, and Native Americans over 10%. There are 23 tribes, nations, and pueblos throughout New Mexico. And almost 25% of our state residents live in some sort of poverty, and that's versus as compared to 17% in the United States. Our geographically sparse and aging population puts pressure on our healthcare system. And while New Mexico is the 5th largest U.S. state in terms of land area, we are only 36th most populous state. New Mexico has on average about 15 people per square mile versus the national average, which is around 80 people per square mile. And while New Mexicans have some form of health insurance coverage, we are an expansion state. About 12% of our residents remain uninsured. So clearly, providing comprehensive health and public health services in our rural areas really becomes challenging, and we also have lack the ability to hire and maintain qualified clinicians and specialists to many of the great distances that we have in our state, and so people are traveling long distances for their health care coverage. On the next slide, I want to share with you some of New Mexico's health challenges that are specific to New Mexico. I won't go into all of the list. You can take a look at that yourselves, but I want to particularly point out one on the list, which is the fact that 40% of New Mexicans live in a primary care health professional shortage area. So you can see that as New Mexico's centralized accredited public health department, we have our work cut out for us. So what we've done is prioritized some key areas, and we are embedding that in all of the work that we do, which includes reducing obesity, reducing diabetes, substance use, and teen births. So all of these areas represent prime contributors to chronic illness and lost years of life, and are risks for virtual illness in all leading causes of death and disability. And so we know that achieving breakthrough reductions in these areas is going to change health status in New Mexico. In addition to prioritizing some of these chronic illnesses and other issues facing our state, we have substantially invested in improving access to health care through one of our important partners, which is Project ASTHO, who collaborates. They work through the University of New Mexico, the Health Sciences Center, and also we work with our Primary Care Association and the Prevention Health Council and others throughout the state on telehealth issues that help break down the barriers of healthcare provision in some of our most rural areas. Using this widely available teleconferencing platform, practitioners working in our most rural areas are able to link with specialty care in Albuquerque, which is our largest city in New Mexico. In addition, Project ASTHO offers opportunity for New Mexico healthcare practitioners to develop and contribute to their abilities to benefit the people in their communities in specific ways with their specific needs. How we do that, one important way is through our community health workers, which are also linked through Project ASTHO, because we know that providing services in our rural communities takes an intricate look from people from their perspective with their disparities. We know in New Mexico that a number of our population predominantly speak Spanish, and so using Project ASTHO and community health workers is an important piece. Thank you.
Thanks,
and on the final slide are just the partners that we collaborate with throughout the state.
Thanks, Lynn, for that introduction to yourself and the context of New Mexico and how you're working with your rural areas. Next, we will turn to Sally Davis. Sally?
Yes, thank you very much for this opportunity, and thanks to Lynn for laying out the background of New Mexico. I'm a professor in the Department of Pediatrics and in the Department of Community and Family Medicine at the University of New Mexico School of Medicine, and the founder and director of the Prevention Research Center. We've been a research PRC since 1995, and we hope to continue. It's a wonderful opportunity for someone in a underrepresented, under-resourced rural state to network with other universities and other PRCs to do the kind of work that we do. My interest specifically is in community-engaged research, especially in rural and frontier communities. Our current work is dissemination and implementation. We've been developing a model for the past 8.5 years that is adapting the community guide recommendations for physical activity in rural communities. We have now scaled up to 31 other communities across the state that are similar, that are small, under-resourced, sometimes isolated from the larger centers. So if we could go to the next slide. So Lynn did a nice job of describing the population of New Mexico. I'll just spend a few seconds on this slide. The dark green is the areas of New Mexico, or the areas of New Mexico that are less than 1 person per square mile. The dark red are the areas of New Mexico that are more than 5,000. So you can see there's not very much red, and there's a lot of green on the map. So this will give you a sense of how spread out and how far apart people live in our state. And next slide, please. So a lot of people think that in rural areas people are more active, and I come across people all the time that are surprised that we're trying to increase physical activity in small rural areas. But if you look at this slide, you will see that in New Mexico, the blue areas are the blue bars. Well, sorry, see if we can go back a slide. Yes, the blue bar are the rural areas in New Mexico, and the red bar are the more urban areas. And as you can see, for all populations and for white, Hispanic, and American Indian, the rural are less active, more sedentary. And that's one of the issues that we're trying to address, knowing that physical activity is critical cross-cutting behavior that can address the prevention of most chronic diseases. Next slide. So we have a beta site, which is a small community that if you could pick a representative community, is similar to many other communities in New Mexico. It's rural, tri-ethnic, under-resourced. But the thing about it that is, the two things that are important to remember is it is surrounded by public land. So one of the things that New Mexico is rich in is a lot of national forests, Bureau of Land Management, and some state parks and state monument and national monuments. So a lot of public lands. It's proximal to the Continental Divide Scenic Trail. These two facts will play into our intervention that I describe later. This community has a 40-bed dialysis center. There are only 800 people that live in the community, but diabetes and obesity is rampant. It is a hub for the rest of the area. So the next slide, please. We work in partnership with the community to address the community guide recommendations for physical activity. And we are adapting those for rural areas and with attention to fidelity of the original research. And so one of the main ones is access to places to be physically active. And so the forests, the trails, the Continental Divide Trail, all of the outdoors is one of the things that we are using to address that recommendation. And the next slide, please. These are some of our key partners. I know that's an important part of working in rural areas. Many of ours are untraditional, so we work Department of Transportation, National Forest, Bureau of Land Management, et cetera. So they're not always those that you would expect to be in public health. Okay, the next slide. And our project is called Viva 1 and then Viva 2, and I won't go into the details, but we do have a lot of successes and building trails and getting people out and doing community-wide campaigns and social support. And we have now scaled up, as I said, to 31 other communities using the success of our beta site. Next. And these are our network communities across the state. Last slide. And this is one of our beautiful areas. If you look real hard, you might see a bright yellow school bus traveling down this road. So thank you very much for allowing me to share some of our exciting work.
So much, Sally. That was a great overview of some of the work you're doing at your Prevention Research Center. So finally, we will turn to Sarah Wilcox and ask her to introduce herself and some of the work that she's engaged in.
Hey. Good afternoon. I'm Sarah Wilcox, and I am a professor in the Department of Exercise Science, and I direct our Prevention Research Center at the University of South Carolina. Our core research project is studying the dissemination and implementation of an evidence-based program in the faith community. And we developed this program in partnership with the African Methodist Episcopal Church in South Carolina. The name of the program is Faith, Activity, and Nutrition, or we call it FAN. So in the first phase of our project, we offered FAN training to all churches in Fairfield County, South Carolina. And it's a county just north of where the university is. Fairfield County has about 23,000 residents. About 60% are African American, and it is a rural and medically underserved county that has higher than average chronic health conditions and also limited access for places to be active. So in this phase, we're partnering with a council of very diverse organizations and agencies who really come together to try to improve the lives, the families, and the communities of Fairfield County. They're called the Fairfield Community Coordinating Council. And one of the things that we've seen in Fairfield County, and I would say in our state in general, but in counties where there is no public transportation, where media outlets are scarce and resources are scarce, churches are really a key resource and a key way to reach out to the population. In the second phase of our core research project, we partnered with the South Carolina Conference of the United Methodist Church, and we're offering the training to churches across the state, and many of those churches are also in rural areas. So the FAN program takes a policy systems and environmental approach. Church committees go through a one-day training, and it's delivered by community health advisors recruited from the areas that we work with. And the churches learn how to increase opportunities and programs for physical activity and healthy eating. They learn how to create healthy church guidelines and policies for physical activity and healthy eating. We focus on engaging and supporting their pastor in making these changes. And then finally, we work with the churches to share messages about physical activity and healthy eating through familiar church channels. Many of the churches also have community outreach as a part of their mission, and so we encourage that these programs be shared outside the church. The program's flexible, so church committees select the type of activities that they think will be best received by congregants within each of these 4 focus areas. And then the community health advisors also provide technical assistance in the form of brief monthly calls to the churches over a 1-year period. The churches get a lot of materials to help support their program implementation. The outcomes paper from the first phase in Fairfield County was recently published in the American Journal of Preventive Medicine. And what you see on this slide is an infographic that we developed with our community partners to show our findings in a more lay-friendly way. So some of the key findings were that 42% of all churches in the county adopted the program, and we were really excited by that adoption rate. We also found that the church committees were successful at making these PSE changes, so they increased opportunities, pastor support, as well as messages. And then finally, fewer members from the FAN churches were inactive compared to those from untrained churches. So essentially, we reduced the rate of inactivity among the churches that were trained. And my final slide just includes some links that may be of interest. So the first link is of the USC PRC website, and we've written up 31 one-page spotlights of churches. So if you're interested, this would give you much more of a flavor of what the FAN program looks like in a given church. The next link takes you to the National Cancer Institute's research-tested intervention programs, and FAN is an index program in our TIPS. And then we were really excited just recently to be linked with the Rural Health Information Hub, where they've included FAN in their rural health models and innovations. So both of those sites will also give you some more details. And then finally, I've included my email address and welcome any contacts or questions you have. And thank you again for this opportunity to be here today.
Sarah, thank you so much for that overview of the FAN program. It sounds like you have some exciting results from that. So good luck disseminating that further along. We're now going to move into some questions that we received from those of you who registered, so thank you for submitting those. We categorized the questions you submitted and created a question guide to capture some of the key points you were looking to learn. So those will inform our discussion today. In the meantime, you are also encouraged to use that chat box if you want more detailed or specific questions answered by our panelists as time allows. So we're going to move to our first subtopic, which has to do with evidence-based programs. And this is the question we'll be asking the panelists to address. How can we adapt and promote evidence-based programs that address policy, systems, and environmental change to rural health settings? So I'm going to first ask Diane to take on this question, and then we'll move through our other panelists. So Diane?
Sure. One of the things that we know is that there is not a lot of direct evidence on what works in rural, and there are a variety of reasons for this. Research is challenging anyway, but a lot of times it's hard to get the numbers that are required for studies to be considered part of the evidence base. One document that our office is working on, we worked with the National Network of Public Health Institutes and Georgia Health Policy Center, as well as HRSA's Federal Office of Rural Health Policy, where we compiled resources on different evidence-based interventions, but also other resources for addressing the 5 leading causes of death in rural America, and that will be available soon. But one of the things that we do know is that taking something that was developed in an urban environment and trying to adapt it for rural doesn't always work, again, for a variety of reasons. Sometimes this is about resources because a lot of interventions are pretty resource intensive, but the other thing that's important to keep in mind is that rural is about more than just geography. It's got a culture, history, tradition that's very different, and those are things that are really critical to take into consideration when you're talking about interventions. So you're really not just talking about geography, you're talking about a population. I'm so glad to see the link for RHI Hub. That's funded by HRSA's Federal Office of Rural Health Policy. There's some great toolkits on there. That's always a good place to start if you're looking for something you want to implement in your community. But I would say that if you do find something you want to adapt, my best advice is find out as much as you can about the drivers of the program's effectiveness, because you don't want to adapt out something that was actually driving the effect, but then work really closely with the folks on the ground to find out what's going to make sense for that adaptation in that community.
Thank you so much, Diane, for that answer. And as we move to the other panelists, I'm wondering whether you can also, in your answers, think about some of these other questions that relate to this question about evidence-based programs and adapting them. So how social determinants of health can be incorporated in the development and implementation of programs. And also, if you're aware of types of public awareness campaigns or promotion that may best be suited for these rural areas. So with that, I'm going to turn the conversation over to Sally to see what she has to say about this topic. I'm not hearing anything from Sally.
Can you hear me now?
Yes.
Okay, thank you. Sorry. So when we adapted the community guide recommendations, it was very obvious that most of the recommendations came from research that had been done in places like Atlanta, Boston, San Francisco, et cetera, and are smaller towns, but certainly not rural New Mexico. And so we have, in all of the communities we work in, there is an advisory group or a guidance council or an alliance. And so they would help us to adapt, but again, without losing fidelity to the original research. So I'm going to give an example of one of the recommendations that's actually has good evidence is access to places to be physically active and informational outreach about those places. And so in our beta site, in the community that we started with, there are no YMCAs, there's no health clubs, there's one very small park, and so they're not really organized places for people to be active. And there's a misconception that rural people are active just in their daily life, but the ATV has changed some of that, and people are not as active as they have been in the past. But as I mentioned earlier, as a setup to this question is that there are a lot of public lands, and these are open for everyone, and creating access to those places, trails, trailheads, advertising that, walking guides, apps, every way you can imagine to promote those places to be physically active has been extremely successful. and also connecting the small rural community to the Continental Divide Trail as a place for people to be physically active. So I think the adaptation comes from the community itself by saying this will work, this won't work, let's try this. And also for us having a beta site that we're willing to try things that maybe we found out didn't work so well before we started promoting and sharing those with other communities.
Thanks so much, Sally. Lynn, do you want to add to anything about what's going on in New Mexico in terms of that, or another component that you all have focused on?
Sure, thank you. Sally did a great job of talking about some specifics. I'll add two more. Three. So the Department of Health embarked on accreditation this year, and whether or not you're a department or an organization that is accredited or able to be accredited, it really has helped us identify certain best practices and evidence-based approaches, which really are guided by, social determinants of health and many of the other systems that have been put in place across the nation. But, critically, we know that in rural areas, health disparities really take on a different form, and they are very particular to various areas. We have 32 counties in New Mexico, and each of them have their own intricate health problems. So the second one I'll talk about is the importance of health improvement processes, which bring together the list, a whole gamut of people from the cross-section of our communities to work on health assessments and health improvement plans, which are targeted in those rural communities. And last, I would mention that New Mexico is the lead in a project to create a rural health policy, and that is through the NCSL, the National Council for State Legislators. And we work with a group of people in New Mexico that come from very rural communities who will help inform what the rural health policies look like for New Mexico. We also have an Office of Rural Health that takes a deep dive into our federally qualified health centers and help us to identify rural health needs. And we put forth, and I can give you the link to our disparities, our rural health report that we put out once a year, which is really a great opportunity to work with our partners to make sure that we are taking a focused approach based on the health assessments of each community.
Great. Thanks, Lynn, for adding that information. Sarah, why don't we turn the stage over to you so you can talk about this in terms of what's going on in South Carolina and the work you're doing with FAN and perhaps other programs too.
Sure. I would say just one, I think, key consideration when you're looking at potential evidence-based programs to bring into rural settings is trying to choose programs that have inherent flexibility built into them. So just to give a concrete example, in the program that we developed, we encourage all churches to choose guidelines or policies, but we don't have a prescribed list of things they must do or programs they must implement, and that's when really the adaptation to local context occurs, where the churches could meet that goal in a lot of different ways that would be best suited, but the inherent fidelity is still met because they're setting a policy related to physical activity and healthy eating. And then I would say the other thing to echo Sally's point, which is that we've always taken any program to the community to get input on what they think will work and not, and have made adaptations to try to make it well suited for the community, and always being mindful of things like literacy levels, cost of the program, even very simple things, but important things like images and references that they really reflect the people in the communities that you work with.
So to follow up on some of the information you all just shared, Sarah, would you talk a little bit more about your process of public awareness or promotion for reaching out to the churches? Because getting out the message is often really hard to do, especially in these rural settings. So if you could talk a little bit more about that, and then I'll ask Sally the same question in terms of reaching out to engage people in more activity through the kind of messaging that happens. So, Sarah?
Sure. Yeah, that's a really key fact because the county we work in really does not have media outlets. So very much there is a lot of word of mouth. There's a lot of the coalition that we're involved in, has people from the library, from the Chamber of Commerce, from early literacy, in addition to your more traditional health partners. And by bringing everyone around the table on a regular basis and then getting consistent messages to bring back to different settings, the likelihood that you can reach people in these rural settings is a lot greater because you're taking the message to where people are coming to anyway. And we found that to be really a key factor in promoting, anything, resources, community programs, our program. It's really through that somewhat more informal mechanism, and then really having some trusted people. So the other good thing about the coalition is the members are really known in the community, they're trusted in the community, and it just makes a world of difference in reaching out.
Okay, and Sally, you want to briefly take a stab at that, and then we'll move on to the next question.
Sure. One of the things that I'm going to talk about the beta site more than the other sites just because of given the short time, but the beta site has a monthly newspaper. Everybody gets it. Everybody reads it. We make sure that every single issue has stories about what's going on, what's planned, what's coming up, photographs of every event that has been used to engage the community. But we also have a website, and we do special events like a full moon hike or National Trails Day or the Public Lands Day, where we have families come out and do a hike together. And the way we advertise those is we do a flyer, and we take them to the grocery store, and the sacker at the grocery store, and this is a very small grocery store, puts the flyer in the grocery bag, and that goes home. We also take it to the school, and every child takes the flyer home, and we generally have a really good turnout. And this covers many of the recommendations. So it's social support, it's community-wide campaign, it's the outreach, the informational outreach, etc. And then we also have branding of our colors and design so that when volunteers are out working on the trail or the park or whatever, everybody in town knows that the people in the bright gold shirts are their fellow, their neighbor, their family, somebody who is volunteering to create a place to be active.
Thanks so much. Those were great tips for reaching out to rural communities and garnering engagement. So the next question we're going to be moving to has to do with data and evaluation. The question is, how can data be leveraged to develop programs and address health disparities for rural communities? This time we're going to start with Sally, and then we'll move to Sarah. So Sally?
Okay, one thing that in New Mexico with the very large counties and the sparsity of population, we use small area analyses so that we only focus on the area that we're planning to or working with or have been invited to come and work with. For example, Sandoval County, which is the county that I've been speaking about for the beta site, also includes a very large metropolitan area next to Albuquerque called Rio Rancho, and the health statistics for that part of the county are, you would not believe that New Mexico had any health issues, but when you look at the far northern part of the county, that's where the health statistics indicate the great need that we have for intervention. So using small area analysis, so countywide doesn't really work. Aggregating data over years because 1 year of data in these small populations is not going to be very helpful, just not enough numbers. We use a lot of qualitative data, so we do a lot of focus groups, interviews, analyses of minutes of meetings, newspaper articles, etc., and find that that is extremely important, particularly for understanding the context and how to adapt an intervention. But the last last two that I'll mention real quickly is we did a health impact assessment, and we did it kind of differently than usually health impact assessments are done. We weren't looking at something bad coming into the community and what would the health health issues be, but we looked at if they put a trailhead for the Continental Divide Trail or any other trails close to town where people didn't have to get in their car and drive to it, but they could actually walk to it, and it had a safe place to park if it was outside of town. Would people use it, and what would be the economic benefits as well as the health benefits? And we spent 2 years on that, and I will say that the National Forest Service and the Bureau of Land Management, who are the land managers for where trails are put and where they can be put, have used that health impact assessment for their decision making, and it has changed what they consider. They're not just considering the NEPA aspects of whether it's endangered species or whether there's a cultural site or whatever. So we feel very, very pleased that that data was able to influence how decisions are made in those big land managers. And then the last is we've had a partnership with DOH since 2003 to do the Youth Risk and Resiliency Survey across the state in the schools. And we have a program called RAPS where those data are taken back to students, and the students analyze the data and come up with suggestions for ways for interventions for preventing the negative aspects.
Thanks, Sally. Sarah, you want to talk a little bit about leveraging data?
Sure. We've used a variety of sources. We do use a lot of existing county data, county health rankings and census data and data from our state health department. The coalition we work with, we also provided technical assistance in doing a community needs assessment in the county. And then as part of evaluating our own program, we surveyed church members. And one of the things that we've tried to do is really share the data back, not just to the coalition that we collaborate with, but to the individual churches as well. And so churches have been able to take it and, it's one thing to have county data and say, we have high rates of hypertension, but to be able to say, of our members, 50% had hypertension, and I think it really can make a difference in hitting home the point and the urgency of the issue. I think part of the evaluation that we did and the data that we collected was helpful for the council in putting together a grant application to the Duke Endowment, which they did receive to kind of further support efforts in the county around health promotion. So we do always try to think of both the evaluation, but then also how the community can use the data to leverage for more funds or for greater impact.
Fantastic. That sounds like the community really benefited from that greatly. So our next question as we move on is about policy. What legislation has addressed rural health, and what are best practices for leveraging funding resources? So I'm going to ask Lynn to address this policy question. Lynn, I think you may be on mute.
Sorry about that. Thank you. So a couple of quick ones that we have recently put into play that have been critical for New Mexico. One is the certification of community health workers. We were the first state to create a statutory program that certifies community health workers through the Department of Health. That is a critical piece to our rural communities, and having that certification is amazing for number one, identifying health access and health impediments, but also leveraging community engagement to create sustainability plans among community organizations so that we have real buy-in from intricate areas. A next important one relates to data. We were successful in creating a new data point for hospital-level data. For many years, we were only allowed to collect county-level data, and so we have now a health information system advisory group that works with each of the hospitals so that we can get data from all of our hospitals, which many of them are in rural communities. And then leveraging funding is, something that we do through some of our partnerships. We meet heavily with so many people in communities. We have programs with county-supported funding from county levels. We are a centralized public health system, and I would just say that working to leverage those opportunities really starts in the rural communities and then finding those engaged members. So I know we're short on time, so I'll end there.
Thanks, Lynn. Diane, I'm going to have you address this question briefly as well.
Sure. So this is just really quick, and this is very much a top-down opportunity, literally called opportunity zones. So opportunity zones are a new community development program, and they were just established by Congress as part of the Tax Cuts and Jobs Act of 2017. And the idea is to encourage long-term investment in low-income urban and rural communities across the nation. This is brand new. Governors just selected the communities, and those are available online right now. And so basically, the idea is that there are tax incentives for businesses to do those investments. And I think this is ripe for evaluation and ripe for really looking at what the impacts on health are when you get good community development going on.
Great. Thanks for mentioning that, Diane. In the interest of getting more questions in, we're going to move on to innovative practices and partnerships. And we're going to focus first on partnerships. So specifically, the question is, describe your experience with community engagement and partnerships to address health disparities in rural areas. And so we're going to start with Lynn again and then move to Sally.
Great. One of the things I talked about earlier on is that we emphasize the importance of health improvement processes. And in order to do that, we have to gather together an intricate group of partners in communities to help us figure out how do we measure, how do we evaluate, and how do we impact the health status in New Mexico. And we're right now embarked in 2018 in our new state health improvement plan, which is done every 3 years. And this is a process that updates the progress of how we're doing, but then it also identifies new impacts to health, and we can work with each and every community organization. We work with our tribes, nations, and pueblos. We work with UNM Hospital in Albuquerque and UNM in general. We have another large school in the southern part of the state, New Mexico State University, that we partner with and looking at health assessments. We have an alliance for health councils that are locally identified individuals who consistently work on the health needs and the health assessments in their communities. And lastly, I would just say that we have a robust relationship with our tribal communities because we have a law that requires tribal collaboration, and that also brings our tribal members to the table to help work on identifying community needs and building those partnerships.
Thanks, Lynn. Sally, would you like to add to that?
Sure. I would like to say that probably one of our best partners is the Department of Health, and we have for a long time partnered on many different projects, but the one I'll mention is Comprehensive Cancer Division of the Health Department has been very interested in the promotion of the role of physical activity in the prevention and control of certain cancers, and the fact that a lot of people sort of overlook the fact that physical activity is important for cancer. They think about heart disease and obesity and diabetes. So we have been working together, and they have supported and funded part of our toolkit with making it possible to have 6 videos of our beta site in their own words that are training videos as well as fact sheets to go with that. And at the time when we had the transition communities through the health department, we did a lot of our training in the venues that they would gather the communities for a training or a workshop, and then we would present the information. And then also the health promotion specialists that work for the health department that are in our communities that we're working with, they are key players in pulling together the groups that are the alliance or the steering committee for the community. The Department of Transportation is the other big partner, and I'll just wrap up by saying that they have funded the putting in sidewalks, street lighting, and are right now have paid for, given a grant to the community that we work with, that we help leverage, to pave the path. It's a mile long around the park, so it could be used in all weather. So really important partners.
Talk about some of the partnerships that you've focused on and developed.
I'm sorry, did you say Sarah?
Yes.
Okay, sorry. Yeah, I think, I would echo the non-traditional partners that I mentioned before. That's been really important. And I think maybe just to comment on the process of partnership, because in some ways we were almost overwhelmed by things like response rates when we went to church and how well people took part in the evaluation and the surveys and the research, and that almost surprised us a little bit. But I think one of the things that, by partnering with these established groups and making sure that we're listening to them, we're incorporating their feedback, and there are no surprises. We're very explicit, we're very transparent about what everything involves, and, not over-promising, but so that I think people feel very comfortable and understand what we're doing and why we're doing it, and even just kind of explaining research and why we have a delayed intervention group. And then the other thing I think for us that's helped is, when we started partnering with Fairfield County, we really just made a commitment to the county. So we're at the monthly meetings, whether or not we have things to share. We provide technical assistance whenever we can, whether it be evaluation, the community needs assessment, grant writing. And so I think that that commitment that has also just made a difference, so that we're not, seen as coming in, doing the project, and leaving. And I think that's been important for our relationship and partnership building.
Thanks for reminding us about that, Sarah, the importance of sticking around in these communities. So keeping in mind that time is fleeing by quickly, we're going to move on to our next question about innovative technology and strategies. Lynn, I'm going to start with you, and the question is as follows. What innovative strategies and technologies exist to improve health disparities in rural settings?
Great, thank you. I think that, for New Mexico, one of the biggest innovative strategies that we have is working with partners better. I think that telehealth, that technology is linking us in a way that we never could before, and so it started with hepatitis C, and it has moved to obesity, other chronic illnesses, heart disease, behavioral health issues. And so utilizing that function, we also use the telehealth component to train our workforce in different areas. We have a large TB population initiative that we're working on right now that is actually hopefully going global soon. And I think that utilizing that technology to link rural communities to evidence-based, best practice, and specialty information, education, and providers is key. Thank you.
Sally, do you have anything you'd like to add what Lynn shared with us?
Just quickly, with our 31 communities that I mentioned, the big thing that we emphasize is them sharing with each other, and we do that with websites, virtual events, a listserv. We have trail apps for everyone. We do Zoom for every meeting, so we're a part of their meetings, and we're developing modules for portal learning, so very important to us.
So I'm thanks Sally for that. I think we're going to have, since we're running short of time, we're going to move to one of the questions. And can you all comment, whoever wants to take the floor, on efforts to promote sustainability about projects beyond the research?
This is Sarah. I think one thing we've tried to think about in our programs is really capacity building and advocacy and leadership training within the communities about the area, so that it's really not dependent on the prevention center delivering the program. And I also think that focusing on policy systems, environmental approaches is another way that, if done correctly, you can have sustainability more so than implementing, individual behavior change programs.
Thank you, Sarah. Lynn, do you want to add any thoughts about sustainability?
Sure. This becomes a little bit of a challenge in a rural state that is dependent on a lot of different funding components. So we work hard to do train-the-trainer opportunities, to link community leaders with opportunities to then leverage some of the work that they're already doing in their communities and infuse these best practice components from the Department of Health, and to give them strategies and guidelines and documents to then better suit their individuals and their communities their way. But again, I would mention community health workers become a really low-hanging fruit for us, and they become our boots on the ground.
Thanks, Lynn. Since we're coming to a close of our session here, I wonder, Diane, if you have any perspective from the part of the CDC on sustainability beyond the research.
So I have one strategy. It's not a CDC strategy, and it's something I just learned talking with some folks that work in rural communities. These would be folks at the NORC Walsh Center for Rural Health Analysis. And one of the things they suggest to small organizations is that when you get funding, try to staff the initiative as realistically as possible. So don't go all bells and whistles, deluxe, high-end, try to be realistic, with the idea being that the funding is probably going to end at some point, and would you be able to sustain it? So the guidance is just try to be realistic going into it.
Thanks for that clue, Diane. That's a very good strategy, I think, over the long haul. We are left with 1 minute, so I'm going to thank our panelists for answering these questions, and also the group for submitting all of these great questions for our panelists to answer. I do want to mention that the CDC PRC's program and the Office of Women's Health are putting together a September 27 webinar focused exclusively on rural women's health. And details about that webinar are forthcoming on the PRC. So I want to thank you again for joining us today, and I want to thank the CDC for sponsoring the Ask the Experts virtual event. Please take this opportunity to fill out an evaluation about today's virtual event. This evaluation provides us with really useful information to help formulate our future programs, and we will email the archived recording and list of resources to all of those who joined us within 2 weeks. So, thank you so much and enjoy the rest of your day.